Hi, this is Brian Kim. I'm going to share with you this case of a patient with a dislocated single-piece acrylic lens. And this is also a dead bag case. This patient has, you can see a bag that looks crystal clear, but it's really diaphanous, thin, and floppy. There's no fibrosis of the bag to the lens, and this patient has an in-the-bag dislocation. And so you're going to see my modified Yamane technique using the J&J Sensar lens. There have been some issues with the other lenses that are out there. And so I'm going to show you how you're able to execute this case with a lens that's readily available to most of us in the United States. And it works very, very well with the 30 gauge thin walled needle, TSK needles. And you're going to see my modified technique in order to perform a very gentle technique on those very delicate PMMA haptics. And I'm going to share the nuances of how I'm able to execute the technique with some illustrations and some pictures here. So you can see this is the dislocated lens. It's in the bag, but you can see it's clearly moving and mobile with pressure on the globe with the cotton tip. And this is the fixed caliper that I got from Epsilon. I'm marking 2.5 millimeters posterior to the limbus. And then I'm using an ink pen to mark each indentation. So again, 2.5 millimeters back. Go ahead and use an ink pen to do that, and then 2 millimeters adjacent. And this is a backward L configuration on the right side. So you're going to see I'm using the ink pen on the right side, and just to contrast, I'm going to do it differently on the left side. So I'm using the caliper to find 180 degrees apart, marking the limbus. So I use the cannula tip on the left side, again using the fixed caliper to go 2.5 millimeters back, and then 2 millimeters adjacent and backward 7 on the left side. And I'm using the caliper tip to mark. Look at the difference in the size of those marks. So much better with the tip of the cannula. So this is a trocar. I'm indenting about 4 millimeters posterior to the limbus. And with a tunnel technique, I'm tunneling about 3 millimeters adjacent, tunneling towards that mark. You're tunneling through the sclera, and then diving down perpendicular. You can see it's a good shelf because the trocar is leaning sideways there. So I'm making my paracentesis incisions on each side, and these incisions are important to help explant that lens. And this is the contra-incisional limbal incision to externalize the leading haptic. And that externalizing of the leading haptic is critical to the trailing haptic first technique. And this is the paracentesis incision for my 20 gauge AC maintainer. Filling the anterior chamber with dispersive viscoelastic and coating the corneal endothelium. And then this is the 3 millimeter keratoma incision. Again, it's directly opposed to that contralateral limbal incision to externalize the leading haptic. Using a two-handed technique, I'm going to go ahead and grasp that trailing haptic, and then grabbing the optic, and then with the other hand, once I secure the lens, I'm pulling that trailing haptic out of the eye, grasping the optic with the forceps in the left hand, and then I'm going to go ahead and bisect the lens. This is a single piece acrylic gummy lens, bisecting the lens about 90%. And because this lens is so malleable, I'm going to pull that first piece out. But before I do that, I'm going to grasp with forceps on the other side, securing that second half, pulling the first half out, using the trailing haptic to pull the optic out. And then as I pull it, it just breaks off, holding the other piece with the forceps still, and then using a handshake technique to pull that second piece out of the eye, and making sure that leading haptic doesn't touch the cornea. I just lift, and then it doesn't touch the cornea. With infusion on, I'm going to go ahead and begin the vitrectomy, going through the trocar. And you want to do good vitrectomy in the area of scleral needle placement. So underneath those marks, I'm spending a little bit more time doing vitrectomy. Again, in dead bag cases, dislocated lens cases, it's been my experience that the vitreous is rather tenuous anyways. It's not like when you do cataract surgery and you have this really dense globules, thick gelatinous globules of vitreous. That's not the case. Late dislocation is in context of liquefaction of the vitreous itself. So this is the right side needle, the 30 gauge TSK thin wall needle. And you're going to see my technique here. This is how I'm bending it, but this is how it's actually going to look in the eye. So I rotated the screen 90 degrees clockwise, and I'm bending at about 9 millimeters from the tip. You can see here, 9 millimeters from the tip, and the bevel is facing towards me. Now, why do I always say that? Because it's very important that the bevel and the needle are parallel to each other, at least when you're trying to cannulate. Now, in the process of docking, as long as the haptic is facing the bevel, like in this case, this is not the ideal situation because there's no way that haptic is going to get towards that bevel. The bevel is towards me. The bevel is actually in the way. You can't hold it that way and be able to cannulate the haptic. They're two different lines. But you see here, I rotate, and now the haptic is actually facing towards the bevel of the needle. You can dock it and then flatten it out. And so that's what I'm trying to illustrate there. That subtle nuance is so important and critical to be able to easily execute the cannulation of the haptic into the needle. This is the left side needle. Since this is the last needle and I'm going to pull it out immediately, you can just bend it at the hub. And that's the reason why I always do that. And again, the bevel is facing away from me. And this is why. If the leading haptic is pointed in this direction like it is now, is pointed towards the bevel, you can flatten it out and then cannulate the haptic into the needle. And this is the 25 gauge needle. It's going to be used to externalize the leading haptic in a no-touch, no-grasp technique. And you can see the bevel is facing to the right, and that's because the haptic is going to be approaching from the right side. And you're going to be able to see what I mean by that when I actually execute the maneuver. So I'm bending it, and you don't have to bend too far back because you're just using it as a docking platform to externalize the leading haptic. You can see here on the left side, the marks are not where they were before, and that's because this patient has a mobile conge. And when there's conjunctival cheilitis or a mobile conge, you always have to be mindful that the marks can move, right? Because the mark should reflect the scleral needle placement, and if the conge moves, it won't. And so you can see here, I'm just remarking because this eye, again, the conge is mobile. Always be mindful when you do that. And so right before you execute the case, you always have to double check those marks and make sure they're aligned in the way you want to. Making sure the mark that's posterior to the limbal mark is radial. And so this is the Sensar lens. This is going into the cartridge here. You want to make sure it's pushed down and nice and flat. As you bring the injector together, you want to make sure the leading haptic goes out, pointed into the barrel. And the trailing haptic is going to be outside and above the injector, as you can see right here. Again, the trailing haptic has to be outside of the barrel of the injector because you don't want to accidentally amputate it when the plunger goes in. So I have the 25 gauge needle contra-incisional. The injector is going in. The bevel of the injector is faced to the left. And look here, my assistant is helping to advance the lens. And you see here I'm missing and it's slipping. As I'm trying to align the haptic into the needle, it's not working. And so why is that happening? Why is this happening? Well, it's rather simple. The reason why I'm slipping is because they're not perfectly aligned, okay? And so what I mean by that is the needle is at the limbus. The injector is pointed down and the haptic is pointed down. And so the haptic needs to point up towards the needle, which is at the limbus. So one of two ways to do that. You can lift the injector up more so that the haptic is facing up, or you can rotate the barrel slightly clockwise so the haptic is pointed up. And so you can see here now, I'm actually slightly nuanced. I'm turning that injector so that the haptic is pointed up. I'm docking it on the bevel of the needle. and it comes out really nicely. And so that is a perfect illustration of just alignment. You want to make sure that the haptic and the needle align. And remember, the haptic always needs to dock on the bevel of the needle. The needle cannot be manipulated, but the haptic can. So once the leading haptic is externalized, again, a no grasp technique, you want to push some viscoelastic to push the optic back. And you see here, this is a really subtle but very important maneuver. I grasp very gently the leading haptic and pulled the optic away from me. And why do I do that? Because I have a better access to the trailing haptic. And so I'm holding the incision, holding the eye in the neutral position, placing the right side needle, tunneling through the sclera from the first mark to the second mark, tunneling 2 millimeters, diving down, clearing the ciliary body, and then rotating the needle into view. And you can see again, because I pulled the leading haptic more external, I was able to push that optic away from me. I have great visibility and exposure of the trailing haptic. And when you go in, you can't just ram the haptic into the eye. I've done this before. What will happen is you're going to kink the haptic. Don't do that. You want to just gently slide it. You can see I'm going to slide it to the left a little bit, slide it to the left. And then once I clear the incision, I go in. And now you can see a beautiful view. And this is so important. You want to make sure you dock the haptic on the bevel of the needle. Make sure they're aligned, make sure they're parallel, and then once they are, then you advance. Never just push. If you push, you're going to kink. And so you want to make sure you align, you can feel and see that it's actually engaged, where the haptic is actually into the opening lumen of the needle. And once it's engaged, you just flatten it some more, and then you gently push once you're in that position, and it glides right in. Very, very important. And once I have that, I disengage the syringe from the needle, and then I'm going to use microforceps to internalize the leading haptic. And again, with my new marks, I'm going to go again from that first mark with the needle, tunneling 2 millimeters through the sclera, about 10 degrees again, tunneling to that second mark, 2 millimeters, diving down and clearing the ciliary body, and then rotating the needle into view. And now, because all the maneuvers are away from you, this is much more easy, even though there is a little bit of tension from the trailing haptic right side needle complex, you still have great control and visibility because you're not working subincisional. That's the tough part with the original technique described by Yamane, is all the maneuvers at the trailing haptic is much more difficult because you're subincisional. And you get that tug of war effect from the leading haptic left side needle optic complex that you're fighting. So you can see here, very subtle. I'm trying to dock the haptic on the bevel of the needle. I'm still working on that, trying to dock it very carefully, trying to align. I'm not pushing. I'm never pushed during this step. I'm not pushing. I'm just trying to, again, dock that haptic on the bevel of the needle. I grasp a little closer, as you saw there, and just a subtle maneuver of my left hand, I was able to just rotate the syringe towards me. And that subtle rotation of the syringe towards me, again, it's very subtle. If you go back on the video, you'll see it. And when I did that, I'm able to engage the haptic on the bevel of the needle. And then once it's docked and flattened out in parallel, I was able to cannulate it. And so with this maneuver, I pull the left side needle towards me, the right side needle away from me. And I like to pull out just a little bit of that needle. And in doing it that way, too much of the haptic is not into the eye. And when I externalize that first haptic, there's not too much tension on the haptics this way. And so that's the reason why I like to do that maneuver. Cauterize the tip on the left side. And then as I'm pulling the right side needle again away from me, you want to make sure that you have your forceps ready to grasp it so it doesn't slip. But again, there's great grip of the needle to the haptic with this Sensar haptic here. Once I cauterize it, I go ahead and push the bulbs flush to the sclera and reapproximate the conjunctiva. You want to make sure you push it nice and flush. If you have a nice small bulb, you won't have extrusion, you won't have this big mound that's coming up from the conj. Oftentimes it's buried and it's hard to really see. It's almost like just under the surface of the conj, barely visible in cases now when you're not heavy-handed with the cautery. Well, with the Sensar, with the PMA haptics, you can't make the bulb too big. Unlike with the CT Lucia, you can actually make a giant bulb, and that's really not a good technique. So go ahead and do vitrectomy some more. And this is a peripheral iridectomy using the Vitrector. Again, IOP 50 fixed, cut rate 30 fixed, aspiration 0 to 12, vacuum 0 to 350. And you're able to go bevel down out to the periphery and engage the cutter. Very well controlled and sized peripheral iridectomy. Doing it this way, it's not too big and it's in the perfect position, because if it's too big, it can cause glare and issues such as that. And so you don't want to do that. Again, I'm doing the iridectomy temporally. So now I'm using the Vitrector and I'm in cortex mode. I'm just removing the viscoelastic from the anterior chamber. And this is a 10-0 nylon suture to close the main incision. I always like to place a 10-0 nylon suture with these cases. Even though there's thorough vitrectomy, you just never know, and I don't want to encounter any vitreous at post-op day 1. Just want to have a nice clean eye. I inject some more intracameral Kenalog as just a final check to make sure everything's nice and clean, using the Vitrector to go ahead and remove the Kenalog from the anterior chamber, and you can see there's no traction, there's no vitreous that's visible in the anterior chamber. Go through the trocar and do some more vitrectomy from the posterior side, and then I'll hydrate my incisions, take the AC maintainer out, the trocar out, and that's the end of the case. So again, this was a patient with a dead bag. Again, the dead bag meant there's a dislocated lens, but the bag looks nice and clear, looks diaphanous and floppy, very little zonular and capsular support. Why does this happen? It's because the change in the zonules and the bag, and it's a combination of both. But definitely there's changes to the vitreous that causes the lens to dislocate. You saw the way I bisected the lens. Because this is a single piece acrylic lens, it's rather easy to amputate and take that lens out. And you saw, again, my technique, externalizing the leading haptic with a 25 gauge needle docking technique. This is a no grasp technique, so you're not damaging the haptic this way. And you're also able to move the optic away from you, which allows better exposure to the trailing haptic. You saw how I mark. I advise using the tip of cannula. It's very precise, and you're able to use that fixed caliper, 2.5 millimeters back, 2 millimeters adjacent, tunneling, clearing the ciliary body, and then cannulating, using the principles of docking the haptic on the bevel of the needle. Don't push until you've docked successfully. If you push prematurely, you'll crimp the haptic. You'll be yelling at yourself for doing that. It's poor technique, and it means that you're just trying to force the issue. It doesn't work that way. You got to dock it, align it, and it takes a gentle and subtle hand. Once you've docked it, you can feel that the haptic is actually at that tip and going in, and then just re-grab and just very gently, very gentle pressure, and go ahead and cannulate the haptic into the needle. It's somewhat of a tight fit with this Sensar PMMA haptic through that 30 gauge thin wall needle, but it does go well, as you saw here. And then you're able to pull out the needle simultaneously, but just fall short of pulling the haptics out. I like to do it this way. It minimizes stress on the haptics, and then you pull them one at a time, cauterize just a little bit on each tip, push the tips back down, flush to the sclera, reapproximate the conj, and that's the end of the case. So this patient did quite well, and again, hopefully you learned something about performing a very gentle Yamane technique using these delicate PMMA haptics of the Sensar IOL. So I hope this was helpful to you, and I thank you for your attention.